Thank you so much. That's just absolutely fantastic. So I was thinking we were here a year ago and wondering what this pathway looked like and just how far we've come. Quite incredible. Thank you so much. The other logo that's been appearing on the screen is the Burnet Institute. The Institute is no stranger to the indoor air quality stage. Founded in 1986, it now stands as one of Australia's foremost medical research and public health institutes. And of course, it's home to Professor Bronwyn King, who we saw from Brazil earlier. Its leader, Professor Crabb, constantly reminds us he's not an indoor air quality person or expert, but there's no escaping that his career-long focus on infectious disease and medicine has built a bridge for brilliant scientists like our next speaker. Associate Professor Suman Majumdar is Chief Health Officer and Deputy Programme Director in Health Security and Pandemic Preparedness at the Burnet Institute. He's a public health expert, researcher and infectious diseases physician. He leads a collaborative multidisciplinary programme of work focused on developing evidence-based and equitable solutions for clean indoor air and on reducing the airborne pathogen transmission, including of an increasing risk for tuberculosis. Right now, his institute is conducting Victoria-funded research on improving indoor air quality in schools, workplaces and other buildings. So please join me in welcoming Dr. Majumdar to the stage as he shares how the Burnet Institute is using this opportunity to clear the pathway to clean indoor air from the laboratory through to policy. Thank you.
Thanks, Claire, and great to have this opportunity to speak. So I'm presenting on behalf of many colleagues and also partner institutions that I'll speak to in this presentation. And note that we've acknowledged country. For Burnet, it's actually the lands of the Boonwurrung people of the Kulin Nation where our institute is based and headquartered. Before I get to this slide, I'll just say two things as to frame this talk. It's really picking up on one point that Anna Maria just made around the evidence-based decision-making and that we don't need to wait for evidence to act. The work that's needed now is research in parallel with implementation. So I'm going to describe in detail what that looks like and the work we're doing to do that. As we implement at large scale, we do need data to inform the next steps and to optimise, and that's really the focus, and we will call that implementation research or implementation science. The second thing is that we are going to focus on airborne pathogens, and that's not to exclude pollutants as and equally, and they go hand in hand. But one area of expertise that we have is in pathogens, and so I will just talk a bit about the details of research on airborne pathogens. This is to say, for pathogens, obviously we've been through a global catastrophic shock with the pandemic that cost lives, destroyed economies, and it still impacts many health systems and societies presently. But there isn't a metric yet on the impact of airborne pathogens, but if you add together what's available, you're talking around at least 12 million deaths per year, at least. That's a conservative estimate. What's not on the slide is indoor air pollution, and that's largely data from low and middle income countries with wood fire smoke in indoor environments. We haven't got the impacts of air pollution in other settings, etc. Now, add to that baseline that's conservative the increased risks that are going to occur with climate change, particularly for pathogens. As you see environmental degradation, you get more particularly human-animal interaction and what we call spillover events that lead to new pathogens and existing pathogens spreading. Climate change itself can increase mosquito vectors, etc., that will increase infections broadly, but from the airborne side, it also can increase people going into indoor environments. So these are all intersecting big issues that we're all facing at the moment. And this culminates in the modelling that shows that there's an increasing risk of pandemics developing, 50% in the next 25 years of another major pandemic. From the policy perspective and what's out there, one of the other reports that was released at a similar event here in Canberra last year, last year, was this evidence synthesis by that was commissioned but reported by the National Science and Technology Council. And just one of the conclusions was that there is limited evidence for the relationship between reduction in viral load and measured infection rates. Now, that could get interpreted as we don't know if this works or not. That's actually not the case. It does point to a gap, but I'll talk through how those gaps can be addressed and why they're not an excuse for inaction. In translating the evidence into policy, another pitfall is probably some of the frameworks we have, and I've experienced this in the other airborne pathogen I work in called tuberculosis, where you have an evolving evidence base, you have real-world data, yet our medical decision hierarchies often have a very clear hierarchy of randomised control trials and gold standard evidence required before you move. That led to the loss of many lives in tuberculosis because we had drugs that we knew that were effective and they were not recommended early enough when you apply these frameworks. An example here for air quality is a 2023 NHMRC guideline review that looked at portable air purifiers in schools and concludes that a lot of text there, but essentially the quality of the evidence is low, and then puts a judgment on top of that there might be costs and resources, energy, etc., and it actually might exacerbate inequalities if you use this intervention. So it's a number of leaps, but it did use a decision framework, which I'll highlight here. And that hierarchy was you see this in medical school, you get taught that randomised controlled trials are at the top of the pyramid, and then reviews of trials called a meta-analysis are even beyond that. At the bottom, you've got laboratory studies, and you've got observational stuff in the middle. This all contributes into a decision framework, which is the certainty of evidence. But when you do make a policy recommendation, as Anna Maria indicated, you have to take into account resources, equity, acceptability, and feasibility. The risks are when committees assemble, and if they are not a diverse composition, that they can take a narrow interpretation of the evidence and make recommendations that are negative for a long time until things tip in the favour. So to address that, we've embarked on a program of work, and we're very fortunate to have funding from the Victorian government to put a program together. And most importantly, this is not something that we're doing alone. Our organisation and my role is to facilitate a group of experts who know a lot more than I do on this area. And I'll come to that in that slide in a second to talk about some of those people and institutions. But if you look at the top row here, we're working across these domains of efficacy and effectiveness, which is really, from a pathogen point of view, it's easy to say that do they work in the lab, do they improve clinical outcomes? And then the domains that are more in the implementation research field, which is acceptability, feasibility, and scalability ultimately. Using this framework is how you can do things, evaluate them, and scale up. And it's what we do for many other health conditions, be it maternal child health programs or primary care or infectious diseases. The three projects, and I'll speak to two of them today. We've got a lab-based research study that's working with the Doherty Reference Lab and many others to look at far UV against tuberculosis and other pathogens. We have a large study that is looking at implementation in schools and workplaces, and a randomised trial. Here are some of the people and the experts we work with across these projects from the University of Melbourne, Professor Monti, who's not here today, and his team, Professor Morawska, of course, Professor Marks, who's now at the Burnet after having a long history of leading NHMRC Centres of Excellence in safe air, which includes outdoor and indoor air. Professor Helen Cox, colleagues from Monash, Simon Jewson, Andrew Stewartson, Robin Schofield, Professor who's here today, and colleagues from CSIRO and the Doherty. So this first project is a 2-year program of work that the goal is to address these implementation gaps to inform scale-up of indoor air quality across Victoria. We're implementing this through the Victorian government, and it's supported and funded through the Department of Treasury and Finance. And that is because Objective 3, which I'll jump to here, is an investment case or a cost-benefit analysis of indoor air quality across the whole of society, schools, workplaces. We'll use some real-world data, and we'll also use estimates from other studies to inform that investment case. We anticipate that work will be done by the end of next year with some interim data mid next year. It's quite a rigorous piece of work that we're undertaking, not a back-of-the-envelope calculation. The other objectives, the first one is to essentially do and evaluate and implement indoor air quality models that have monitoring and implementation. And secondly, number three there is the policy framework. So to work through policy options for the government that go from guidelines, regulations to legislation. The interventions are here at the bottom. They include starting with monitoring on sensors, displaying them in some settings. We're using low to medium cost interventions that are focused on ventilation and filtration. Specifically for the air quality nerds, they are heat recovery ventilation systems and in-ceiling purifiers. We're not really using portable air purifiers, only in a minority of spaces to really test their acceptability. So these are more inbuilt interventions. And in some rooms, we're also going to test different degrees of automation versus user response. Largely leaning towards automation, but we will also test how much users such as school teachers and office managers can actually use and interact with these settings. One of the research methodologies is quality improvement, and that's a lot of implementation science is applying words to things that are quite obvious. We plan something, we study it and measure it, and then we act again, and it's a feedback loop and cycle. So that's how we'll work across these spaces to put something in place, have user surveys and feedback, and then refine the model and keep going. I described the interventions earlier, and here are some further pictures of those with the in-ceiling purifiers and the heat recovery ventilation units that Jason Monty and his team have been at the key of selecting and installing. I will say that installation has been challenging and complex because it's the first time we're doing it at such scale. But it's not insurmountable, and it will be feasible. But it's kind of like doing 229 renovations simultaneously, so it's a pretty stressful job for a very small team to do it across a lot of sites. But that will be one of the challenges we solve. Once you do it at scale, you learn, and then you can speed up and do it better. Things that come into play are, as many of you would know, asbestos in ceilings, not enough roof space, different demands from different rooms, etc. So we have, in these rooms and spaces, we'll have indoor air quality sensors, outdoor air quality sensors, the interventions, and some rooms will have a display. The displays we'll be able to see and the managers can see, and then some rooms will have a dashboard. The second project is the Elucidar study, which is in partnership with the Department of Health this time. And this was a long program of work which did start with discussions that Lydia and Brendan Crabb and that some of us had with the Victorian Government around germicidal UV and its potential role. This is one where it's an old technology and we were figuring out how and when it can be used. And there was a decision to implement it, and our advice was to implement and evaluate at the same time. Rather than rolling it out without any evaluation, let's try and roll it out in the context of doing a clinical trial. So it was very different to other clinical trials, which take years of planning. They're all planned out and resourced. This was a trial on the fly, and it has been a complex project, but it will have many lessons learned. It's still underway. We're only at 12 months, and we're yet to report results, but I'll show you some of the objectives and the experiences. So germicidal UV is an old technology that's been in use since the 1930s. It is actually recommended by the WHO for pathogens including tuberculosis, and the US CDC in the pandemic put out guidelines for its use or advice for its use for COVID-19. Lab studies demonstrate that GUV can inactivate airborne viruses and tuberculosis. And there are two types of germicidal UV, upper room, illustrated in the blue, and then whole room, which beams into the occupied zone in the purple. This trial is looking at the older technology, which is the upper room GUV, because that was available and had existing guidelines when the work was conceived in 2022. There is a lot of work accelerating on far UV at the moment. The methods for this trial, so this looks at evaluating the effectiveness and safety of upper room GUV in residential aged care in Victoria. It's a cluster randomised trial, which means the clusters are aged care homes, and they're large homes, 75 residents. We have 30 that receive the GUV in their common rooms and 30 that have just their standard interventions. The objectives are to look at COVID incidents as well as other pathogens. We've just taken a decision to extend this study beyond 12 months, and we're going to keep evaluating it every 6 months. Now, I'll pick this up in the panel discussion around the pitfalls of randomised trials, but I'll just go to say that as we've implemented, the picture on the right shows that the real-world setting was a lot more complex than we envisaged. We knew it was complex, but the lesson was when you install upper room GUV, you've got aged care homes with things such as chandeliers in the way, ceilings that are very different shapes. TB hospitals, where I've seen use this technology, is a box room. You can implement it easily. The real world is a bit different for this. That did impact dosing and the speed of implementation. We conducted our own lab study just to validate the devices, again showing that GUV works and is effective as portable air purifiers. This is the variation in dosing, it's a plot of effective air changes from dosing measurements across all the rooms where we installed. So there's over almost 2,000 lights installed in aged care in Victoria, and there's quite a variation in dose. That's probably the main message. And for a trial, you want this as standardised as possible. So we're going to take this as an input into the analysis, that there is a degree of variation. But at the end of the day, we're getting at least 8 effective air changes in these common rooms, which is a significant uplift to what is a poor baseline. So in conclusion, for indoor air quality interventions, guideline developers and policymakers should balance scientific rigour with implementation urgency. We don't need to wait for the gold standard to act. We need to implement and evaluate as we go. If you conduct a randomised controlled trial, it must be well designed and adequately powered to be useful. There are a number of trials that are negative results, and they're probably not helpful if they're at small scale. So we will have more to say about that as we have the results of this larger trial. And finally, policy improvement requires multiple levels of evidence, not just gold standard trials, but lab studies, real world implementation, complemented by implementation research. Thanks so much.